Hello everyone, this is Dr. Shivangi Tiwari and today we will discuss Preimplantation Genetic Testing. I'll be covering this topic under the headings of Introduction, History of PGT, what are the types of PGT, what are its indications, methods, counseling, details of methods, controversies regarding PGT, take-home message and references. So let's begin. What exactly is PGT? PGT mein what it involves is, first we have to do IVF. After doing IVF, we have to create embryos. Then we have to take the biopsy of the embryo, or less commonly polar bodies, for genetic testing, and transfer selected embryos into the uterus based on the results of the genetic testing. So if we talk about history of PGT, it started from 1937, but it is there in 1990 that Alan Handyside he did successful clinical PGT for X-linked disorders. Until now, we are seeing some new things are adding in PGT. So, if we talk about what are the types of PGT, so there are 6 types of PGT. PGT-A for aneuploidies, PGT-M for monogenic disorders, PGT-SR for structural rearrangements, PGT for HLA, that is human leukocyte antigen matching, PGT for polygenic disorders, and PGT for mitochondrial DNA. So, most common indications for PGT. So, indications for PGT are PGT-A. Indications are if a lady is of advanced maternal age, most commonly it is more than 35 years. So, if a lady comes to us with more than 35 years, we should advise her PGT-A. Then, recurrent pregnancy losses, repeated IVF failures, and in some cases severe male factor infertility is there, then also we can advise PGT-A. Next is PGT-M. For PGT-M, indications are if there is any family history of lethal X-linked disorder in males, known alteration in an X-linked gene, carriers of autosomal dominant or recessive conditions, if there is a family history of gene defect for late onset autosomal dominant disorder. And when we talk about PGT-SR, then its indications are parent with Robertsonian translocation, parent with other translocation or structural rearrangement, parent with inversions, deletions or duplications. So, what are the methods of PGT? PGT may we can take the genetic material either from the polar bodies from the oocytes that is taken on day 0 or day 1, or we can take blastomeres from early cleavage stage embryos that is taken on day 3, or we can take trophoectoderm cells from blastocysts that is taken either on day 5, 6 or 7. So, first is polar body biopsy. What is polar body? So what happens is, during meiosis, these polar bodies, they separate from the immature ovum and they result in a large mature oocyte and release of 2 small polar bodies. So timing is, polar body biopsy we can do it simultaneously when both polar bodies are collected together 16 hours after insemination, or we can perform polar body biopsy sequentially, like first polar body we can retrieve before insemination, that is we can take 4 hours after oocyte retrieval, and the second one we can take after fertilization, that is 16 to 18 hours after insemination. So and what are its uses? Uses are maternal if we want to know the maternal genetic contribution, maternal origin meiotic aneuploidies if we have to rule out, or maternal pathogenic variants, or we can do polar body biopsy in countries where there are legal restrictions on genetic embryo evaluation and cryopreservation. In those countries also we can go for polar body biopsy. Now, what are the advantages and disadvantages? So, if we talk about advantages, so polar body biopsy kya hai? What we are doing in polar body biopsy is we are doing preconceptional manipulation. Why? Because it is not an embryo yet. So, whatever we are doing on polar body, that we have collected from oocyte, so it is not an embryo yet. So there is no influence on the future development of the embryo. Next advantage is because polar bodies का कोई genetic contribution तो नहीं है. Whatever is there oocyte, polar bodies are like a waste material, right? Next is they are useful for maternal structural and numerical chromosomal aberrations and in certain monogenic diseases. Its disadvantages are it's an indirect method. Why? Because जो oocyte है that is going to be a future fetus, जबकि जो polar bodies हैं there is like an extra material. And we are taking the extra material for the genetic, to check for the genetic material, right? So that's an indirect method. Second thing is, it detects aneuploidies that are originated only from the maternal origin, because we are checking oocytes, we are not checking sperms. So 66% of the embryonic aneuploidies only we can detect, leaving 1/3 of the aneuploidies undetected. Next disadvantage is, it is not very cost effective. So its limitations are, it has a limited ability to predict the genetic status of the embryo, because we are checking only oocyte, not the sperm or not the paternal contribution. Second thing is, oocytes, they must either be fertilized or cryopreserved before the results of polar body biopsy are available. Suppose we have taken polar body from one oocyte, and what if in future what if in future ये जो oocyte था, ये आगे जाके embryo ही नहीं बना, then what is the use of checking that oocyte, that whether it is euploid or aneuploid? No use, right? Third thing is, it is very time consuming and it is not cost effective, as biopsies, they need to be performed at inconvenient hours. Next comes cleavage stage biopsy, that is also known as blastomere biopsy. What we have to do in blastomere biopsy is, it is performed at 6 to cell stage, that is around 72 hours after insemination. It is advisable to remove 1 to 2 blastomeres for genetic testing. तो जो day 3 पे when we get cleavage stage, that is day 3, 6 to 8 cell stage, we can remove 1 to 2 blastomeres out of 8 cells. So, but the problem is, everywhere it is written we can take 1 to 2 blastomeres for genetic testing. But what we should take? Should we take 1 or 2 blastomere? So if we take 2 cells, so it is there that if we are taking 2 cells, then biopsy is going to be more accurate. But it can affect the embryo vitality. Why? Because it results in the removal of around 30% of the whole embryo. Okay, then we should think about 1 cell. But if we take 1 cell biopsy, then it can lead to the misleading or the incorrect diagnosis. So what we should take? Nowhere it is given. Like, that's why it is not nowadays we are not using, because if we take 1 or 2 blastomeres, it is going to affect the vitality of the embryo. Timing, when we should do it: beginning of the blastomeres compaction process, which starts at around 8 cells and completes at around 32 cells prior to cavitation. Embryos, they are commonly exposed to the calcium and magnesium free media for 5 to 10 minutes prior to doing the biopsy, which helps in loosening of the cell adhesion, allowing for easier manipulation. Its advantages are, it allows detection of maternal, paternal and early post-fertilization defects as compared to the polar body biopsy. It gives enough time for genetic diagnosis if we are performing it on day 3 and transfer on day 5. So it enables us for fresh transfer, which is not possible with day 5 biopsy. Its disadvantages are, only 1 or 2 blastomeres can be retrieved, and analyzing only 1 or 2 cells, it does not allow the detection of potential mosaicism. So potential mosaicism we can miss with a day 3 biopsy. Now, when we do a cleavage stage biopsy, like suppose if we have taken only one cell from this, right? सपोज हमने एक सेल लिया बायोप्सी में और वो सेल यूप्लॉइड निकला, बट और जो बाकी जो बचे जो सेल्स थे उसमें मोस्टली सेल्स एनिप्लॉइड थे, तो इट कैन कॉज फॉल्स पॉजिटिव रिजल्ट, राइट? एंड सपोज हमने जो बायोप्सी सेल लिया, इट कम्स आउट टू बी एन्यूप्लॉइड, बट जो एम्ब्रियो है उसमें जो बाकी जो remaining cells they are all most of them are euploid, so it is going to give us a false negative result. So this can lead to a possible misdiagnosis. So that's why there is a third thing, that is the most popular thing, and we are doing this only, and that is trophoectoderm biopsy. That is advisable. Blastocyst, trophoectoderm biopsy from blastocyst. What is blastocyst? Blastocyst is achieved 5 to 6 days post fertilization, and it contains around more than 100 cells. When we have to take the biopsy, between days 5 to 7 following oocyte retrieval, and we can take 5 to 10 trophoectoderm cells. See, this is the blastocyst, and this is the inner cell mass. These are the trophoectoderm, and outside is the zona pellucida. So we have to puncture the zona pellucida. We have to take 5 to 10 cells of the trophoectoderm, and this is the genetic material we can get. This trophoectoderm biopsy is recommended by the 2020 European Society of Human Reproduction and Embryology, that is ESHRE PGT Consortium on biopsy technique. See, trophoectoderm. If we take trophoectoderm, see this trophoectoderm, it is going to be future placenta, while this inner cell mass, it is going to be a future fetus. One thing, its advantage is when we are taking trophoectoderm, so it is going to be a future placenta. तो अगर हम trophoectoderm ले भी रहे हैं तो it is not going to affect the viability of the fetus. This is the good thing. But the bad thing is that we are taking trophoectoderm, which is going to be placenta, but it is not going to be fetus. तो क्या concordancy is there between the trophoectoderm and inner cell mass is there or not, that we don't know. It has been proven by various studies that there is 100% concordancy, but the exact thing nobody knows. So there are 3 methods of doing trophoectoderm biopsy. First method is we have to open the zona pellucida opening on day 3. Then we have to incubate it until herniation occurs. Once herniation occurs, we can take the biopsy of the hatching cells, but there is a risk of inner cell mass herniation is there in this. Next is we can go for zona pellucida opening on day 5, and in that either we can go for direct intrazonal aspiration of cells and taking the biopsy, or we can wait for the spontaneous herniation to occur and then we can take the biopsy of the hatching cells. Third is we can do the zona pellucida opening on early day 5. We have to incubate it until herniation occurs and then we can take the biopsy of the hatching cells. Now, advantages of trophoectoderm biopsy are, when we are taking trophoectoderm biopsy, we have like 5 to 10 cells. So we have a large amount of data that is available for analysis. So इससे sensitivity and specificity increase होती है. Then chances of detecting common mosaicism is more as compared to other types of biopsies. Then trophoectoderm biopsy is not directly involved in fetal formation, so it is not going to affect the viability of the fetus. Next thing is likelihood of inconclusive diagnosis is less than 5%. There is a higher survival rate compared to embryos at the cleavage stage. So obviously अगर कोई embryo day 5 तक आया है, then it has a higher chances of survival. Then Johnson et al. They suggest that there is a 100% concordance between trophoectoderm and inner cell mass genetic makeup with exception of structural abnormalities. Its disadvantages are it requires a skilled and highly trained embryologist. Second thing is जितने भी हमारे good quality day 3 embryos हैं, it is not like that all of them are going to grow as till blastocyst stage, so we can miss some of the good quality day 3 embryos in between. Third thing is there is a need for cryopreservation of biopsied blastocysts. We can't do fresh embryo transfer. Then we are taking trophoectoderm, we are disturbing the placenta, the future placenta, so there is an increased risk of preeclampsia and hypertensive disorders of pregnancy if patient conceives. So next is, what are the methods of zona opening? We can go, there are 3 methods. There are mechanical opening, there is partial zona dissection, there is a chemical opening via acid tarot solution, and third thing is laser. First is mechanical opening. Mechanical opening, that is known as partial zona dissection, and it involves making a slit in the zona pellucida by a sharp closed micro needle. And this partial zona dissection is of 3 types: standard partial zona dissection, 3D partial zona dissection, and long partial zona dissection. This is 3D, it is a cross shaped slit we have to make. So standard PZD, it involves we have to stabilize the embryo with the holding pipette that is placed at a 3 o'clock position, so that the part of the embryo with the greatest perivitally space, it comes out at 12 o'clock position, and the PZD micro pipette, they were placed through the zona pellucida at 1 to 2 o'clock position and create a 30 to 40 mm of slit through which a biopsy micropipette that is placed to aspirate the blastomere, or the biopsy micropipette was used to compress the embryo to expulse the cell. Then 3D PSD, 3D PZD, that is same, like that's a cross shaped slit we can make. Then long PZD, it involved placing the greatest perivitally space at 6 o'clock position and passing the PZD micropipette through both the sides of the zona pellucida, entering at 5 o'clock and exiting at 7 o'clock. So the micropipette was then used to cut the zona pellucida against the bottom of the dish for a larger slit. It is going to create a larger slit. Next is chemical opening. Chemical opening, it is done with acidic tyrrhode solution. What it is? It has a pH of 2.4 containing of sodium chloride, potassium chloride, calcium chloride, magnesium chloride, glucose and polyvinyl pyrrolidine. It is streamed onto the zona pellucida through a drilling micropipette until the zona pellucida is breached, and then we have to quickly remove it with aspiration. What it does is it creates a larger hole. In this picture you can see it creates a larger round hole than as compared to the partial zonal dissection, and we have to do the embryo wash after acidic tyrrhode solution exposure. It is useful for early cleavage stage, but it is inappropriate for oocytes because it can damage oocytes. Third is laser. This is the most recommended. Laser, it is non-contact laser, easily adapted to the microscope. It is transmitted through a 45x objective. It reduces time of biopsy procedure. It is quick, simple, safe and efficient with no need for micropipette changes. It has no mechanical, thermal or mutagenic effects. So this is best. Next thing comes, what should be the timing of biopsy? Should we do it on day 3 or day 5 biopsy? So one study, they proved that then they compared the day 3 with the non-biopsied control and day 5 with the non-biopsied control, and what they found is there is a 39% relative reduction in day 3 sustained implantation rate as compared to the non-biopsied control, while day 5 biopsied and when they compare day 5 biopsied with the non-biopsied control, the sustained implantation rate was equivalent. So best is day 5. Next is they compared day 5, day 6 and day 7 biopsied, and what they found is there is no significant difference between the euploidy or aneuploidy rate in day 5, 6 and 7 blastocysts. So you can do either on day 5, day 6 or day 7 according to your convenience. Next comes counseling. Counseling is one of the most important part of PGT. So whenever we are thinking of doing PGT, we should do a proper counseling of the couple. So couple, they must be aware of what are the limitations of PGT. There are a small risk of misdiagnosis which can be because of biological reasons like mosaicism. There can be some technical reasons or human error, and this counseling should be done by an experienced individual prior to proceeding. Now, we have to tell the patient that PGT results are not definitive, and even after doing PGT and even after transferring euploid embryos, confirmatory prenatal testing with CVS or amniocentesis is recommended for all the pregnancies who conceived via after PGT-M, SR or PGT-A to rule out misdiagnosis due to mosaicism. And among them, amniocentesis is the preferred method for genetic testing during pregnancy because it evaluates the chromosomal status of the fetus rather than the placenta. Then we have to tell the patient about the sampling errors that can occur during PGT. Why? Because see, we are taking biopsy of one or more cells at the blastocyst stage. It may not be representative of the entire trophoectoderm, right? Second thing is trophoderm ploidy. It does not reliably represent the inner cell mass. So taking 5 or 10 cells of the trophoectoderm, it is not going to represent the whole trophoectoderm. Second thing is the trophoectoderm, it is not representative of the inner cell mass, which is going to become an embryo later. Third thing is these ploidies, they may self-correct after the blastocyst stage, and based on data, 50% of embryos that they'll be discarded because of aneuploidy of the sample cells, they have the potential for implantation and pregnancy. Next thing is we have to convince the patient, we have to do the counseling of the patient regarding the possibility of false positive results that can lead to discarding potentially normal embryos, that can lower the chances for pregnancy. False positive results, they can arise because of random biopsy of a small cluster of cells in an embryo with over 100 cells, or in the way a laboratory interprets mosaic results. Suppose see this picture, हमने इस पार्ट पे बायोप्सी लिया, तो उस बायोप्सी में मोस्ट ऑफ द थिंग्स आर एंड मोस्ट ऑफ द सेल्स आर यूप्लॉइड बट वन सेल इज एन्यूप्लॉइड. जबकि अगर हम अपोजिट साइड से लेते जब अबव साइड से लेते तो वो एन्यूप्लॉइड है. इट इज मोजेसिज्म वी कैन मिस इन सच केस. सेकेंड केस कि में हमें मोस्टली चीज़ें सेकेंड लाइक इसमें देखिए हमने यहाँ कहाँ से हम बायोप्सी ले रहे हैं वो मैटर कर रहा है. जैसे सेकेंड केस में हमने बीच में से लिया तो हमें ये लगेगा कि इसमें एन्यूप्लॉइड मतलब मोस्टली सेल्स आर एन्यूप्लॉइड, तो ये जबकि मोज़ेक है तो हम मिस कर सकते हैं. तो कहाँ से हम बायोप्सी उस टाइम पे ले रहे हैं उसके अकॉर्डिंग रिपोर्ट आएगा, तो वी कैन मिस मैनी थिंग्स. सो नाउ वील डिस्कस दीज PGTs in detail. First is PGT-A. Its aim is to identify any numerical chromosomal abnormalities, that is aneuploidies in embryo, to allow selection of euploid embryos for transfer and to reduce the likelihood of implantation failure or miscarriage. It is considered as an add-on to IVF treatment. When we do PGT-A, the potential biopsy result can come as either euploid, aneuploid, mosaic or no result. What if report comes as euploid or aneuploid result? So the prevalence, if it is euploid, we are going to transfer. If it is aneuploid, we are not going to transfer. Simple. Prevalence of aneuploidy, it range between 25 to 90% depending on the patient's maternal age. Aneuploidy rate of embryos at blastocyst stage in women of advanced maternal age of mean 39 years old is around 55%. There are ART calculators that can be used to predict the number of mature oocytes that are needed to have one euploid embryo, and these ART calculators are very helpful in your practice to counsel the patient. They act as a useful counseling tool for couples who are considering PGT-A. This is the ART calculator that you can find online. It's a novel predictive tool to estimate the number of mature oocytes required for obtaining at least one euploid blastocyst for transfer in couples undergoing IVF or ICSI. See, what we have to do in this, we have to add the female age, we have to add the sperm source, like whether it's an ejaculate or it's a donor sperm, whatever it is. Then if it is azoospermia, what was the type of azoospermia, then success probability. Then we will get, according to the patient age and the sperm source, we will get the number of oocytes required to get one euploid blastocyst. Now, suppose a report comes as mosaic. So, what is what are mosaics? The result from mitotic errors that occurring after fertilization. So, in polar body biopsy, we are not going to find them. But there are concerns with PGT in mosaicism. What are these? See, हमने cells लिए टोफैक्टोडर्म biopsy से, but they are not going to represent the whole embryo. Second thing is different techniques we are using for comprehensive screening of embryos, and all these tests, they have their different sensitivity and specificity of detecting mosaicism. Third thing is it has been shown in studies that these aneuploid embryos, they do implant and they can result in a healthy live birth. Now, prevalence of true biological mosaicism is estimated to be less than 1%, so it is very rare. Reported incidence of mosaicism, it is 73% in cleavage stage embryos because we are taking only one cell, 2 to 50% in blastocysts, while during pregnancy it is less than 0.2%. Embryos are considered, according to PGDIS guidelines, embryo is considered to be non-mosaic euploid if it is less than 20% non-modal DNA. If it is considered non-mosaic aneuploid if it is more than 80%, and anything between 20 to 80% is known as mosaic. What if report comes at mosaic? What we should do? We should tell patients, we should counsel our couple that embryos that show less than 50% aneuploidy, they have yielded a favorable live birth rates. We can transfer mosaic embryos, but we have to consider prenatal screening following mosaic embryo transfer. Mosaic embryo transfers are possible provided the patients have been adequately counseled. Now, now report can come as no result. Its frequency is 1 to 3%. It is rare, but it can come. Reasons can be poor embryo quality, biopsy technique was not correct, some problem with the shipping conditions, or technical failures. So, we have no euploid embryos left and only embryos are there with no result. What we should do? We should go for rebiopsy, And results from the studies of rebiopsied embryos, they showed that a result is obtained in more than 95% of cases, and the majority were euploid with favorable pregnancy outcomes. So we should do rebiopsy in such cases. Now, advantages of PGT-A. Advantages of PGT-A are higher likelihood of a successful pregnancy and a reduction in spontaneous miscarriages. We will be able to transfer single euploid embryo, reducing the risk of multiple pregnancies. Time efficiency, providing rapid results, enabling embryo transfer in a short time frame, and psychological benefits are there. Its limitations are inability to consistently detect mosaicism, thereby risking the transfer of an embryo with chromosomal abnormalities. Impact of the procedure on the embryo, as removal of some cells from the embryo, it may determine a slight impact on its viability. Possibility of false positive and false negatives, ethical consideration, cost increase in addition to IVF, and the probability of inadvertently discarding viable embryos. Next comes PGT-M. PGT-M, its aim is to avoid transferring embryos that are affected by a specific monogenic disease. Testing, what we are doing in PGT-M is we are testing for nuclear DNA pathogenic or likely pathogenic variants that can cause monogenic disorder. Pathogenic or likely pathogenic variants with autosomal dominant, autosomal recessive, and X-linked inheritance pattern, they may be tested. Its limitations are hereditary genetic diseases that can be caused by different mutations on the same gene or mutations on different genes. They can lead to similar phenotypes that can mislead us. Second thing is, these diseases, they can be influenced by environmental or epigenetic factors. They can be influenced. Next thing is, by these tests we can detect variants of uncertain significance that can further complicate the result interpretation. That can generate uncertainty about which mutations actually represent a concrete risk in terms of developing the disease. Next is, there are risk of allele dropout, amplification failure, contamination are there. Then determining the haplotype through SNP array, it requires a sample from at least a first degree relative of the carrier partner. If it is not available, this can lead to reduced SNP informativeness. Next is, it is not indicated in cases of large gene deletions or duplications or de novo triplet expansions because phasing of the at-risk haplotype is not feasible. Next is, these PGT-M, they are very laborious and costly procedure and they require extensive preliminary family study. Next is PGT-SR. PGT-SR is for structural chromosomal rearrangements. What are structural chromosomal rearrangements? They include reciprocal translocation, where two different chromosomes, they exchange segments with each other, or Robertsonian translocation, where an entire chromosome attaches to another chromosome at the centromere. Others are deletions, duplications, inversions. Its limitations are difficulty in predicting the precise clinical impact of a given rearrangement. It can complicate genetic counseling and reproductive decisions. Variability in chromosomal rearrangements, they add significant complexity to PGT-SR. Diversity of rearrangements, challenge in identifying breakpoints, these patterns, transmission to the next generations, they demand thorough genetic assessment and careful planning. Next PGT is PGT-HLA. PGT-HLA aim is to allow for embryo selection to create an HLA matched sibling for an existing child who may require a hematopoietic stem cell transplantation. Suppose कोई चाइल्ड है, उसको बीटा थैलेसीमिया है या SCID है या फेंकोनी एनीमिया है, कुछ हेमाटोलॉजिकल मैलिग्नेंसीज हैं. सो नेक्स्ट चाइल्ड को हम ऐसे एम्ब्रियो को वी कैन सेलेक्ट कि HLA मैच सिबलिंग वी कैन मेक सो दैट hematopoietic stem cell transplantation we can do for the elder sibling. So PGT-HLA, it may be combined with PGT-M and select an embryo HLA mesh with the existing child and that is unaffected by the disease. PGT-P is for polygenic disorders. Its aim is to reduce the risk of polygenic disorders like type 1 diabetes, heart disease and cancer. Its indication is in the strong family history is there of a particular polygenic disorder, but it is controversial and it is only offered in a very small number of clinics worldwide. Next comes PGT mitochondrial DNA. It specifically targets the mitochondrial DNA within embryos. Its indication is if there is a risk of transmitting mitochondrial DNA diseases from the mother to the offspring. These diseases, they can result from mutations or abnormalities in the mitochondrial DNA, and they can lead to a wide range of clinical manifestations like neurological disorders, muscle weakness, and organ dysfunction. Next comes non-invasive PGT. This is something new, non-invasive PGT, and this we can do either by blastosynthesis. We can take this blastocele fluid, or we can go with the analysis of the spant culture media. Now, if we do the blastosynthesis, it has its own fallacies. It is unknown whether if we if we take the blastocele fluid, so loss of this blastocele fluid, it could alter the cell to cell communication or the communication of the embryo with its environment. If the DNA material that is obtained from the blastosynthesis, whether it is representative of the embryo DNA or not, it is unknown. Next thing is, we can go for the spant culture media. What happens is कि सपोज बॉडी में मतलब एम्ब्रियो में कोई एनिप्लॉइड सेल है, तो इट इज़ either it will undergo autophagy or apoptosis, then secondary necrosis, then उसके जो भी DNA है, it is going to be there in the spant culture medium. Or extracellular vesicles, and they also cause cell-free DNA in the spant culture medium. This we can take processes such as apoptosis, cell lysis, cell debris during embryonic development in embryo culture. They cause the DNA of the cells to break and they form cell-free DNA fragments that we can use. Next comes, what are the molecular techniques in PGT? PGT approaches, like in PGT-A aneuploidy, the methods are, we can go for FISH, RACGH, quantitative PCR, or next generation sequencing. Non-invasive, we can go for next generation sequencing. Minimally invasive, next generation sequencing. For monogenic disorders, there are linkage analysis, sequencing, that is NGS, next generation sequencing. Next is expanded PGT, SNP array, PGT-SR. If it is balanced, then karyotype FISH we can go for. Next comes, so one by one we will discuss. First is FISH, that's fluorescent in situ hybridization. It's screen common chromosomal aneuploidies, that is 13, 18, 21, X and Y, but all the chromosomes we can't analyze using FISH, that's why it is no longer widely used. Second is whole genome amplification. So in that, all the 23 pairs of the chromosomes, they can be analyzed simultaneously and with greater accuracy by using microarray based tests. Processes, we have to transfer the cells to a tube and we have to do the cell lysis followed by genome amplification, that we can do either by polymerase chain reaction or multiple displacement amplification. We can get more than 20 microgram of DNA from a single cell. Next is array-based CGH. In array-based CGH, it can analyze all the 24 chromosomes. What we have to do is, we have to first take the DNA, we have to do the whole genome amplification, then we have to label it with the fluorescent labels, and we have to take the उसके जैसा we have to take the DNA for the comparison, then we have to do the genome array hybridization, then we can go for the then we will do the analysis. It has a good resolution limit of 6 to 10 megabase, that is suitable for PGT-SR. It is very rapid, within 24 hours we get the report. Error rate of less than 2%, but its disadvantages are its high cost, inability to detect polyploidy, and the lower detection rate for mosaicism due to the non-availability of the chromosome specific cutoffs. Next is quantitative PCR. Quantitative PCR is a high order real-time multiplex PCR reaction. It amplifies several loci from each chromosome along with their quantification. It's a genome-wide comparison. Results are very fast in just 4 hours, but its disadvantages are because we are assessing a small number of loci of each chromosome, its resolution is not that good. Next is SNP array, that is single nucleotide polymorphism array. What is SNP? SNP is a variation in a single nucleotide at the specific position in the genome that occurs at an appreciable frequency within a population. This array allows the genotyping of hundreds of thousands of SNPs across all chromosomes. Its advantages are standardized procedure. Time to diagnosis is time is very less, and we can do PGT-A, PGT-M, PGT-SR concurrently. Its drawback are its higher cost. Analysis, it is limited to the inherited pathologies. We can't do SNP array for the de novo mutations due to the need for a reference. Next is next generation sequencing. In that we have to do the whole genome amplification via multiple displacement amplification, and then we can do the sequencing. So amplification of DNA with priming, allowing for genome wide sequencing. Advantages are we can do non-invasive PGT by using NGS. It complements array CGH by providing additional information on SNP level sequence variations and chromosomal abnormalities such as balanced translocations, and it is the present gold standard for PGT. Next is karyomapping. Karyomapping, it is based on linkage analysis, and it is based on SNP array technology, and it determines an individual's genotype by analyzing thousands of SNPs that are distributed across the genome. It marks a transition from a family or disease specific diagnostic approach to a genome wide approach. So what is the accuracy of testing in PGT? So most recent ASHRAE consortium on PGT-M, they reported that misdiagnosis occurs in less than 0.1% of cases in PGT-M. So it's good. Next is what we should do as an insemination in PGT, whether we should go for IVF or ICSI. So 2020 ASHRAE PGT consortium, they recommend ICSI as the insemination method of choice in PGT cycles, while ASRM committee opinion in 2020, what they are saying is ICSI for PGT in the absence of male factor infertility should be limited, because where actually होता क्या है कि ICSI जो sperms होते हैं ना, like if we are doing IVF, तो जो extra sperms होते हैं, they can these extraneous sperm cells, they can contaminate and they can alter the accuracy of the test results. So if there is no male factor infertility, so they are saying if there is no male factor infertility, then there is like no need to go for ICSI. So we only have to balance what we want. Next is obstetric and neonatal outcomes following PGT. So there are possible associations between embryo biopsy and an increased risk for small for gestational age fetus and low birth weight babies for blastomere biopsy, and there is an increase in the preterm delivery and birth defects in the case of trofectoderm biopsy. And for both biopsy methods, there is an increased risk of hypertensive disorders in pregnancy. Next comes, what are the controversies regarding PGT? So there are ethical arguments that favor PGT. These are everybody has the right to reproductive choice. Medical successes are there of preventing inherited genetic disease, so we should use them. Avoiding abortion after post-conception genetic diagnosis we can do, and it can reduce the societal burden of disease. Ethical arguments against PGT are its cost, misdiagnosis due to mosaicism and other causes, unknown procedural risk, unknown benefit in the context of unpredictable medical advances over time, its possible negative effects on individuals who are living with or have predisposable conditions with given genetic disease. Now, areas of ethical debate include people are doing PGT for adult onset conditions, sex selection outside of medical indications people are doing, transferring of mosaic embryos and embryos that are affected by known pathogenic variants based on patients' wishes. So, take home message is if there is an inherited disorder, we can go for PGT-M or PGT-SR. If it's a de novo condition, we can go for PGT-A. Newer techniques of trofectoderm biopsy and array-based methods, they can allow testing of they are allowing us for testing of all the chromosomes. Cost effectiveness of PGT, it needs to be evaluated before it's widespread use in clinical practice. It's a valuable procedure, but for time being it is not suitable for every patient and definitely not for every IVF patient. These are my references. Thank you.